This is a pseudophakic patient having trifocal IOL implanted a few years ago. He came to us with drop of the visual acuity. He presented with macula of retinal detachment and giant retinal tear. Of course, we decided for pars plana vitrectomy, and we are performing 25 gauge chandelier-assisted vitrectomy. What you saw so far, it was the core vitrectomy. Now we are checking the posterior vitreous detachment, the posterior hyaloid detachment, and it is not needed in this case for triamcinolone because we can see quite well the hyaloid which was already detached. And now we are performing peripheral vitrectomy, taking care first of the area, of the temporal area where the giant retinal tear is. As a matter of fact, it extends from 12 o'clock up to 7:30 hour. We inject peripheral carbon in order to stabilize the posterior retina. And now we are taking care of the GRT area. We cut and aspirate with a vitrector the anterior margin of the retina in the area of GRT. So the anterior flap, the anterior margin of the GRT. The PFCL is injected up to a bit lower than the posterior margin of the GRT. We are now continuing with the shaving up to the ora serrata and even more around the trocars. We are taking care of the superior and inferior margin of the GRT to be well trimmed. And now we perform the posterior vitrectomy and shaving of the vitreous in the nasal half of the retina, getting as close as possible to the retina, up to the ora serrata and higher, around the trocars. So like we do in all our standard retinal detachment cases. We injected more PFCL, more close to the posterior margin of the GRT, and now very carefully we want to detach all the vitreous traction of this margin, which is, as you can see, everted, meaning that it is tracked, it has traction, and if you cannot unroll this margin, it is preferable to cut it completely. So we want to avoid any vitreous traction on this margin. We managed to do this, and now we are marking with diathermy the margin of the GRT and its posterior limit. And now we are filling with more with the PFCL in order to overpass the whole GRT. And under PFCL we put endolaser around this giant retinal tear. 3 or even 4 rows, taking care not to forget the extremities of this giant retinal tear. Under higher level of PFCL, we notice that there are still some vitreous remnants in the anterior periphery, as you see with that transparent line, meaning that vitreous is still there. So we want to improve our shaving on 360 degrees. We want to clean as much as possible of the vitreous. And now we are performing fluid air exchange, having the vitrector in the area of the GRT, trying to aspirate as much as possible and as careful as possible the BSS between the PFCL and the air, and also to dry as much as possible the giant tear. We are doing this using the vitrector and then the backflush cannula, taking care especially on the margin and on the limits of the retinal tear. And now we aspirated the heavy liquid. You can see a nicely attached retina under air with no retinal slippage or faults. And then we injected a silicone oil. We checked the IOL pressure. We removed the trocars, and this is the end of the surgery. 2 months later, we removed the silicone oil, and we left the eye filled with air. You can see how nicely the laser scars are around almost half of the eye. This eye had a beautiful anatomical and functional result. Thank you.